Hello, good evening, and I'm Michelle Batty and I'm the Programme Manager for EUROGEN, which is the European Reference Network for Rare Urogenital Diseases and Complex Conditions. And I'd just like to take a couple of minutes just to explain a little bit about what EUROGEN is and does. So EUROGEN is one of 24 European reference networks created by the European Commission in 2017, and they cover most medical fields, all aiming at improving care for patients with rare diseases. And in EUROGEN, we deal with rare urogenital diseases and complex conditions. So our aim really is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery. So really where the expertise is rare. So some of the activities that we conduct, and now we're currently 57 healthcare providers across 20 member states. So we collaborate on doing virtual cross-border consultations using a secure IT platform that's provided by the European Commission, and that's called the Clinical Patient Management System. So I would strongly encourage any of you out there who is a healthcare professional working in the EU with a tricky case, please don't hesitate to get in touch with us. We'd be delighted to offer our expertise, and the service is completely free. We also collaborate on clinical guidelines, training and education activities. We're very excited to be building a patient registry. So already over 25 of our healthcare providers are contributing their patient data, which will be very important for research purposes in the future. And then I'm delighted to announce that we've also just published this book on rare and complex urology. So I do encourage any of you interested. It's published by Elsevier, but again, if you want more details, get in touch via our website. So this evening's webinar is presented by Dr. Davide Dalla Rosa, who's a pediatric surgeon, and Dr. Luisa Patanè, who works in Obstetrics and Gynecology. And they're both specialists at ASST Papa Giovanni XXIII Hospital in Bergamo, Italy. And tonight's webinar is about congenital anomalies of the kidney and urinary tract from prenatal diagnosis to postnatal outcome. And the aim of the webinar is to evaluate prenatal and postnatal parameters that correlate with the probability of a pathological diagnosis and the need for surgical treatment. And they'll also discuss the usefulness of urinary tract dilation classification system in their experience. So the webinar is accredited for CME accreditation points if you are a live attendee. So without further ado, I'd really like to thank our experts for sharing their experience with us this evening, and I hope you enjoy the webinar. Good evening.
Good afternoon. I'm Luisa Patanè, an obstetrician of the Hospital Papa Giovanni in Bergamo, Italy, and today I'm going to give a little talk about prenatal diagnosis of CAKUT, the congenital anomalies of the kidney and urinary tract. I declare to do not have a conflict of interest about this topic. Let's start from incidence. We have to remember that the CAKUT is a group of anomalies with a large clinical spectrum that range from severe malformation to potentially milder malformation. They account for 1/3 of all fetal anomalies, and in 30% of cases are associated with not renal anomalies from other organs. The incidence in the general population is low, is about 0.1–0.7%, and also is low the mortality rate correlated with this kind of anomalies, but we have also to remember that can play a causative role in half cases of dialysis in children. Like I told you before, CAKUT are a large spectrum of different anomalies. Most of them, about 1/3 of them, and in some studies also half of them, are urinary tract dilatation. What about the embryology? We already know that kidney develops in 3 stages. The first one is called pronephros. In this period, there is a transient, a rudimentary and non-functioning system, okay, and the tubules drain directly into the cloaca. The second period is called mesonephro. In this period, we have the formation of the primitive glomeruli because the tubules, each tubules becomes associated with the local blood vessels forming the primitive glomeruli. In this period there is a production of only a small amount of urine for the embryo. The third and most important period is called metanephros. This period starts from day 28, and in this period the metanephric blastema and the ureteric bud reciprocally interact to induce organogenesis, so to induce the formation of the kidneys that grow with the caudal to cranial direction, and in this period the urine production starts. So the CAKUT defects can occur throughout the fetal development. Different anomalies depend on the time of action of the noxa pathogen. Severe defects occur in the early gestational age, less severe in the late gestational age. The CAKUT pathogenesis is multifactorial. In 10-20% of cases, we can find monogenic anomalies. In another 10% of cases, pathogenic copy number variants. We have also to remember that CAKUT is a component of more than 200 of fetal syndromes. Also, some drugs can play a role with their teratogenic effect. Like antihypertensive drugs, and vitamin A deficiency in the animal models plays also a role. The maternal chronic disease are risk factors of CAKUT, like epigenetic factor that can influence or modify the size, the number, and the development of the kidneys and the urinary tract. We can have a different kind of CAKUT anomalies that can range from the complete agenesis of one kidney to some problem about the urinary tract dilatation. So this slide describes the different CAKUT anomalies. We can have a problem of number of kidneys, for example, agenesis or supernumerary kidney, of size, hypoplasia or kidney, or of position like ectopia or malrotation. We can have CAKUT inside a bigger syndrome that include a lot of other anomalies. We can have CAKUT for kidney dysplasia, like the kidney disease, and at the end we can have the dilatation of the urinary tract, upper and lower urinary tract, that can be obstructive or non-obstructive. For this we have to remember that half of CAKUT are dilatation of the urinary tract. And what we can see prenatally and how? Sure, the gold standard is sonography, and we can see kidneys from 12 weeks, the cortical medullary differentiation starting from 18 weeks, and the renal pelvis that are lower than 4 millimeters in the second trimester and lower than 7 in the third trimester. Also, the renal length can be compared to normal charts, so we can monitoring the growth of the kidneys during pregnancy. What about bladder? It's visible from the 11 weeks between the two umbilical arteries. The wall is thin, less than 2 and 3 millimeters, and it fills and empties every 30-60 minutes. Normally in the prenatal life, ureters are not seen, and at the second trimester, most of the CAKUT can be diagnosed by sonography. The diagnosis of CAKUT can be made also from the first trimester. In this photo you can see the two kidneys laterally to the spine, the bladder and the pelvis, and with the color Doppler the two umbilical arteries surrounding the bladder. In the sagittal planes, we can see the normal bladder. Normal length is lower than 7 millimeters. And also in the parasagittal planes, we can see both left kidney, the adrenal gland, and the stomach. The last view is the coronal planes that we use. This is very useful, especially when we want to demonstrate the presence of both the kidneys, the adrenal gland together, and also in this size, in this plane, we can use color Doppler to help to identification of the kidneys. So going back to the classification, we have to remember that we have different kind of CAKUT of disease, so we will have different kind of fetal sonography. One example of pathology of number is the bilateral renal agenesis. In this case, we have the congenital absence of both kidneys. It's a lethal malformation linked with anomalies in the 7% of cases. The sonography cannot show the presence of the bladder because it's empty between the two umbilical arteries in the pelvis, and in the coronal view we cannot demonstrate the presence of the two kidneys and the renal artery. Also, the anhydramnios is an indirect signs, but is a tardive one because in the first trimester the production of the amniotic fluids is due to the placenta to the membranes. We have to remember that if the renal agenesis is unilateral, not bilateral, there is can be a compensatory hypertrophy of the other kidney. We have pathology of position, like the pelvic kidney, or the pathology of position and size, like the horseshoe kidney. In these cases, we have a failure of proper migration from pelvis to the abdomen. The pelvic kidney remain below the aortic bifurcation, and for the horseshoe kidney, we have a fusion in the lower part of the bone. In the prenatal period, we can also see kidney with dysplasia, like the infantile polycystic kidney disease. It's a genetic syndrome, and 1/3 of these cases can be seen prenatally or neonatally. The sonography shows a symmetrical enlarged kidneys, hyperechogenic kidneys, and with the empty bladder or hyperechogenic bladder in the first trimester. Normal kidneys that is excluded this diagnosis because can be seen only postnatal. In the adult disease, the kidneys are also enlarged with multiple cysts. Normally, this disease is diagnosed in the adult life. Sometimes, occasionally, we can see the same situation prenatally. Dysplastic kidneys can be seen also in some prenatal syndromes. One example for all is the Meckel-Gruber syndrome, in which we can find polycystic kidneys, encephalocele, and polydactyly. For this reason, it's important to remember that every time we see a CAKUT, we must do a detailed sonography of all the other part of the fetal anatomy. Let's start to speak about the most common CAKUT anomalies. Is the urinary tract dilation. The fetal hydronephrosis of the urinary tract is the dilatation of either the fetal renal pelvis alone or the both renal pelvis. That can be diagnosed during the prenatal life, and the incidence is about 1 to 5% of all pregnancy, but it accounts for half cases of prenatal CAKUT. We have a male predominance and is unilateral in the majority of the cases. We have to remember that can be a soft marker of trisomy 21, especially the mild one. For this reason, it's important a detailed assessment of fetal anatomy, because if it is isolated, is not so linked with this anomaly. Speaking about the etiology for UTD, we have to remember that in half of cases can be transient or physiological, so no fetal anomalies linked with the UTD. But in the other cases, we can find fetal renal disease like uretary pelvic junction obstruction, vesicular reflux, obstruction of the part of the junction between ureter and vesicle, and megaureter. The incidence of CAKUT, so the incidence of disease, every time we can see the urinary tract dilation, is proportional to the severity of the UTD, the bilateral involvement, the post-bladder obstruction, and the oligohydramnios. So we can have a ureter pelvic junction obstruction. In this disease that account for 1/3 of prenatal UTD with a male predominance, we see a dilated renal pelvis and calyx without a dilatation of the ureters. In the other 1/3 of cases, prenatal UTD could be secondary to the vesicular-uretary reflux. The reflux could be primary, this is most common form of reflux, and is secondary to the incompetent or inadequate closure of the junction, which contains the intravesical portion of the ureter. The secondary reflux is less common and is secondary to the high pressure inside the bladder that results in some failure of closure of the during the bladder contraction of the junction of during the bladder contraction. It accounts for 1/3 of UTD, and we have a variable hydronephrosis which increases after voiding, plus the ureteral dilatation. The third most common cause of UTD is the uterovesical junction obstruction. In this disease, the sonography typical sign is the megaureter that can be primary due to anomaly or delay in the development of the muscle in the distal ureter, or can be secondary, typical to important reflux. We see uretary dilatation with the uretary caliber that modify with the peristaltic waves. In 25% of cases is bilateral. In the 2014, a group of panel of radiologists, nephrologists, urologists created this classification system. This is important because this stratifies the severity of the UTD on the basis of gestational age and takes in account a lot of multiple sonography parameters, not only the dilatation of the pelvis. And they divided the UTD in two big groups in the prenatal period: a low risk, in which we can find only the dilatation of the pelvis, and they also give us a measure normally of the pelvis in the second trimester and in the third trimester, and a second group with an increased risk of postnatal pathology, in which yes, there is the classical dilatation of the pelvis, but it can be seen also some anomalies of the kidneys, parenchyma. You can see also some anomalies of the ureters, anomalies of the bladder, and also unexplained oligohydramnios. In this paper, they speak also about the management of UTD. In the low-risk group, they suggest a repeat US at 32 weeks in the third trimester, but in the second group, with the high risk of postnatal pathology, the sonography follow-up must be done in 4-6 weeks. The important is also that the prenatal counseling is shared with the pediatric urologists, like we do normally in our patient, and the time and way of delivery is not modified from CAKUT pathology, but we have to remember that especially in the second group is important an examination, first examination of neonates after 24-40 hours after the delivery. In the last slide, I'm going to speak about fetal luto. Luto is the obstruction of the lower urinary tract. It's a rare disease, but with a big impact on mortality and morbidity of the fetus and neonate. The etiopathogenesis is related to an obstruction of the outflow from the bladder during the development of the urinary tract, which leads to a progressive dilatation of the bladder, thickening of the bladder wall, and a subsequent ureteronephrosis with compression of the parenchyma of kidneys and reduction of amniotic fluid production. In most of cases is in male and caused from a problem with the posterior of ureteral valves. In some cases is secondary to a urethral atresia or urethral stenosis. With sonography in the luto disease, we can see a megacystis that it can be diagnosed since the first trimester with the bladder diameter more than 15 millimeters. The dilated posterior urethra, and this is the typical sonography sign, the KO signs, the intraureteronephrosis, and the oligohydramnios. Oligohydramnios diagnosed before 20 weeks gives to the fetus increased risk of death and also neonatal death. Luto is a evolutive disease with a 50% of perinatal mortality, 60% of renal transplant in the survivors. Some multi-parameter scoring system to stage the severity of luto and to predict postnatal outcomes have been proposed, but have not been clinically adopted because we don't have a real prenatal parameter that is linked with the postnatal disease. Two fetal interventions were studied to treat prenatally this disease. One was the placement of a shunt between the bladder and the amniotic cavity. Normally, the placement is made between 20 and 27 weeks of gestation and is associated with a higher perinatal survival at up to 6 months, but did not affect the survival at 1 year or at 2 years of neonatal life, and moreover did not improve postnatal kidney function. The second intervention is the fetal cystoscopic laser ablation of the PUFs. This intervention improved perinatal survival compared with no treatment, but no different with the shunt. In addition, were described 10% of urological fistulas. For this reason, based on existing evidence, prenatal intervention should be offered only in selected cases, and the parents should be made aware of the residual risk of long-term disease in the neonates. Prenatal luto must be referred always to a third-level obstetric center with a multidisciplinary equipe. The last slides with the take-home messages. CAKUT are 20-30% of fetal anomalies detected in prenatal period. 30% are associated with other not renal anomalies or genetic disease. For this reason, it's mandatory a complete ultrasound examination every time we saw a CAKUT in prenatal life. The counseling must be shared with the pediatric urologist and should be offered to all the patients according to the fetal and neonatal prognosis. Prenatal CAKUT should not ever change time of way of delivery, and for the luto, prenatal diagnosis is very important because severity and correct management of this disease can guide clinical approaches and decisions. Thanks.
So that was our presentation from Dr. Patanè. We are going to move on to the second presentation from Dr. Davide Dalla Rosa.
Good evening, everyone. I am Dr. Davide Dalla Rosa, Pediatric Surgery Department, Ospedale Papa Giovanni XXIII Bergamo. I'm here to talk about the postnatal diagnosis of CAKUT. I have no conflict of interest. Like we said earlier, congenital anomalies of kidney and urinary tract represents the most common birth defect and the cause of up to 50% of end-stage renal disease in the pediatric population. In the postnatal period, the first ultrasound to evaluate CAKUT should be done at least at 48 hours from birth and within 1 week. The urinary tract dilation classification system is a comprehensive classification tool that helps us define the gravity of urinary tract dilation. In the postnatal period, the UTD classification consists of 3 groups. UTDP1 comprehends urinary tract dilation with an anteroposterior renal pelvis diameter between 10 and 15 millimeters, associated with central renal calyceal dilation. UTDP2 comprehends urinary tract dilation with an anteroposterior diameter more than or equal to 15 millimeters, with peripheral calyceal dilation and possibly abnormality in the ureters. Finally, UTDP3 comprehends urinary tract dilation with an anteroposterior diameter more than or equal to 15 millimeters, with possibly peripheral calyceal dilation, renal parenchyma abnormalities such as parenchymal thickness or echographic abnormal appearance, abnormality in the ureters or in the bladder. In the 2021 update of the urinary tract classification, there was a modified few parameters, mainly considering in the UTDP3 group the presence of a lesser pelvic dilation, but in association with renal parenchymal abnormalities, abnormalities in the ureters or in the bladder. The UTD classification also could help us guiding in the setting of a standardized follow-up for these patients. Mainly, the authors suggest us that in the UTDP1 group, the follow-up ultrasound should be done in 1 to 6 months. The execution of avoiding cysto-uretrogram and the start of an antibiotic prophylaxis should be at discretion of the clinician, and the execution of a functional renal scan is not recommended. In the UTDP2, also the follow-up ultrasound should be done in 1 to 3 months from birth and should be discretion of the clinician, the antibiotic prophylaxis, the avoiding cysto-uretrogram, and the functional scan. Finally, in the UTDP3 group, the execution of the follow-up ultrasound should be done within 1 month. The voiding cysto-uretrogram and the antibiotic prophylaxis are recommended, and the execution of a functional scan is at discretion of the clinician. To accurately measure the anteroposterior pelvis diameter, we needed to evaluate a transverse view of the kidney with the calibration of the maximal intrarenal pelvis diameter, not considering the extrarenal pelvis diameter. Also, the postnatal ultrasound allows us to differentiate more accurately the different degrees of calyceal dilation, central or peripheric calyceal dilation. It is of great importance also to evaluate the hyperechogenicity of the renal parenchyma, the echographic abnormalities such as the presence of cortical cyst, and to evaluate the thickness of the renal parenchyma. All of these assessments are subjective. So we can see different ultrasound as examples. In the UTDP1 grade, the anteroposterior renal pelvis diameter less than 10 millimeters, the presence of central calyceal dilation, and the normal renal parenchyma. In the UTDP2 grade, the anterior posterior renal pelvis diameter less than 10 mm, the presence of central and peripheral calyceal dilation, and the normal renal parenchyma. And finally, in the UTDP3 group, the presence of peripheral and central calyceal dilation, ultrasound abnormalities of renal parenchyma with small cortical cysts, and also, don't forget the bladder, in this case with the trabeculated walls. Regarding the correlation of prenatal data, postnatal data and CAKUT, we want also to share with you our experience. After an extensive literature study, we also ask ourselves if there is a correlation between prenatal data, postnatal data and outcome in children with a urinary tract dilation CAKUT. We conducted a retrospective study between January 2017 and May 2023 of the patients evaluated in our outpatient prenatal diagnosis clinic and in our pediatric surgery department. We included in our study all the mothers with clinical and echographic evaluation in our prenatal diagnosis unit and the patients born in our hospital and in follow-up with our pediatric surgery department. We excluded the children not born in our hospital or mothers not evaluated in our outpatient prenatal diagnosis unit. We evaluated all the demographics, clinical, instrumental, prenatal and postnatal, biochemical and surgical data. In this flowchart, we want to present our clinical flowchart with a newborn with urinary tract dilation. In suspicion of lower urinary tract obstruction, the clinical conduct becomes more aggressive. In case of a urinary tract dilation, we divide the patients based on urinary tract dilation classification. We perform on average 2 ultrasounds, the first at least 48 hours after birth and within 1 week, the second at 1 month. The second ultrasound is performed almost in every patient because we have a dedicated neonatal ultrasound outpatient clinic, but we are evaluating the cost and benefits of this second ultrasound performed globally. With the result of the third postnatal ultrasound, also, we divided patients based on the UTD postnatal for an appropriate follow-up schedule. Between January 2017 and May 2023, we had collected data from 82 patients, mothers and children. 55% of the patients presented with a simple urinary tract dilation, pelvic dilation with or without ureteral dilation. 22% of the patients presented with renal dysplasia and 23% of the patients with other form of CAKUT, bladder and urethral anomalies, duplex systems, posterior urethral valves, kidney number and position anomalies. We decided to consider separately duplex systems and posterior urethral valves for the anatomical and clinical complexity as compared to pelvic and ureteral dilation alone. In the group of patients with renal dysplasia, we can see that the concordance between prenatal and postnatal diagnosis is almost 100%. In the group that we define other CAKUT, we consider our complex duplex systems, ureteroceles, bladder exstrophy, posterior urethral valves and other forms, as shown in the descriptive analysis. In the group of patients with CAKUT with an urinary tract dilation, we collected the data of patients with pelvic and ureteral dilation alone. We can see 58% of patients presented with pelvic dilation and 42% with pelvic and ureteral dilation. The mean birth weight was 3,300 grams, 66.7% of patients are male, the mean age of mothers at birth is 31 years. The majority of the mothers were at the first pregnancy. The most common maternal pathologies found in this group were gestational diabetes and hypothyroidism. The fetuses have no major anomalies associated, only a few patients presented with associated gastrointestinal anomalies and congenital heart disease. In the majority of cases, the delivery was by vaginal route, and in 1 case alone, we found familiarity for CAKUT. The prenatal data that were analyzed were those included in the urinary tract dilation classification: renal pelvis diameter, ureteral dilation, parenchymal thickness, parenchymal abnormality, hyperechogenicity, calyx dilation, and bladder anomalies. The majority of the patients were in the UTD A2-3 group. Also, the postnatal data analyzed were that indicated by the urinary tract dilation classification. We see that the majority of patients fills the UTDP2 and UTDP3 category. In this table, we can see the comparison between prenatal and postnatal diagnosis and that the concordance between prenatal and postnatal diagnosis in our group was 68.9%. The definitive diagnosis were ureteropelvic junction obstruction in 22.2% of patients, vesico-ureteral reflux in 24.4% of patients, ureterovesical junction obstruction in 4.4% of patients. The remaining of the patients were transient urinary tract dilation. 51.1% of patients were solely observed, 28.9% of patients underwent surgery, 11 patients for a ureteropelvic junction obstruction, and 2 patients for ureterovesical junction obstruction. Mean age of surgery was 10.5 months, and no patients in this group evolved in end-stage renal disease. To correlate prenatal data, postnatal data, and outcome in CAKUT with simple urinary tract dilation, we divided the total number, 45 patients, in 3 groups. The Group 1, transient urinary tract dilation, 23 patients. The Group 2, urinary tract dilation due to pelvic ureteric pathology, 10 patients with ureteropelvic junction obstruction. The Group 3, urinary tract dilation due to ureterovesical pathology, 12 patients in total, 10 patients with a vesico-ureteral reflux and 2 patients with a ureterovesical junction obstruction. We then performed an univariate analysis of demographic, clinical, instrumental, follow-up data, pregnancy, fetuses, and neonates between Group 1 and Group 2 and between Group 1 and Group 3. As shown in the table, the correlation between prenatal data in Group 1, transient dilation, and Group 2, pelvic ureteric pathology, shows no statistical significant difference, unless for the intrauterine growth restriction that is more prevalent in the pelvic ureteric pathology group compared to the transient dilation group. Regarding prenatal data, we found that anterior-posterior renal pelvis diameter was greater in the group of patients with pelvic ureteric pathology with statistically significant difference. Regarding postnatal data, we found renal pelvis diameter and parenchymal abnormalities more prevalent in the Group 2, also based on urinary tract dilation P classification postnatal. The Group 2 contains more intermediate and high-class patients. Regarding the analysis between Group 1, transient dilation, and Group 3, vesico-ureteral pathology, we found no statistical significance in mother and pregnancy data. Also, the prenatal data of Group 1 versus Group 3 shows us no statistical significant difference. Regarding postnatal data, we found that anterior-posterior renal pelvis diameter, the presence of ureteral dilation, the abnormal renal parenchyma are all more prevalent in Group 3 vesico-ureteric pathology than in Group 1 transient dilation. And based on UTDP classification, also Group 3 contains more patients of intermediate and high grade. In the 45 patients group with CAKUT with simple urinary tract dilation, we evaluated the outcome: surgery, pathologic diagnosis, high-grade vesico-ureteral reflux, diagnosis of ureteropelvic junction obstruction and of ureterovesical junction obstruction as a bad outcome. We therefore performed an analysis of the Kaplan-Meier curves and an estimation of the hazard ratio between the Group 1 surgery pathological diagnosis, 22 patients in total, and the Group 2 observation alone, 23 patients in total, evaluating the main parameters relating to prenatal and postnatal ultrasounds: anterior-posterior pelvis diameter in millimeters, ureteral dilation, dilation of the calyces, hyperechogenicity abnormality of renal parenchyma, and the thickness of renal parenchyma. The event-free survival curve based on renal pelvis diameter shows us that an anterior-posterior renal pelvis diameter more or equal to 15 millimeters is correlated with a worse outcome, with an hazard ratio of the postnatal AP-RPD of 3.43. The analysis of outcome based on the presence of ureteral dilation shows us no statistical significant difference, as well as the analysis of outcome based on the presence of a calyceal dilation. The event-free survival curve based on parenchymal thickness shows us that postnatal thin parenchyma is correlated with a worse outcome, with a hazard ratio of the postnatal thin parenchyma of 3.82. Finally, the event-free survival curve based on parenchymal abnormality shows us that postnatal abnormal parenchyma is correlated with a worse outcome, with a hazard ratio of 2.61. The UTDP classification and stratification tool is also associated with clinical outcome in our experience, as shown in the curve and the hazard ratios. The more the grade of the UTDP, the worse the outcome. So, congenital anomalies of kidney and urinary tract are the most frequent diagnoses of congenital defect on prenatal ultrasounds. Postnatal ultrasound at birth is another essential and complementary tool in the evaluation of CAKUT. The presence of intrauterine growth restriction is found more frequently in patients with pelvic-ureteric junction pathology dilation. An anterior-posterior pelvis diameter is statistically greater in patients suffering from pelvic-ureteric pathology dilation, both on prenatal and postnatal ultrasound scans, in our experience. In patients affected by pelvic-ureteric pathology dilation, renal parenchymal abnormalities are found more frequently on postnatal ultrasound. In the group of patients with vesico-ureteral pathology dilation, there is a greater presence of ureteral dilation on ultrasound at birth, renal pelvis dilation at birth, and renal parenchyma abnormality on ultrasound at birth. The presence of an anterior-posterior diameter of the pelvis more or equal to 15 mm on postnatal ultrasound increases the risk of surgical intervention or pathological diagnosis, as does the presence of thin renal parenchyma and abnormal parenchyma on postnatal ultrasound. And compared to the UTD antenatal risk stratification suggested by the UTD classification, the UTDP postnatal risk stratification correlates more strongly with the probability of a pathological diagnosis or the need of surgical intervention. Our study limit is the small number of patients analyzed. A higher number could strengthen the statistical significance of prenatal data. Therefore, multicenter studies could be useful in the future to corroborate the data regarding the correlation between prenatal data, postnatal data, and the outcome of congenital anomalies of the kidney and urinary tract. The use of the urinary tract dilation classification system is a useful tool that allows the use of a common and shared language among the various specialists involved in the CAKUT treatment process. Furthermore, the UTD classification guarantees a risk stratification tool, both prenatal and postnatal, which, in addition to being useful in standardizing the follow-up of patients affected by CAKUT with dilation of the urinary tract, also correlates with the probability of a pathological diagnosis or the need for surgery. Thank you very much for the attention.
So that was our second presentation. I would like to invite our presenters to put their cameras on so we can move on to the discussion section of this webinar. So if you have any questions in the meantime, you can type them in the questions field and we can start answering them.
Okay, so one question is the postnatal follow-up UTDP-free PLO uretral obstruction with less than 10% function. There are space for tube nephrostomy. Yes, we performed in 2 cases tube nephrostomy in the neonatal period for major pelvic dilation and a little function on the functional scan, and we then performed in around 1 year of age of the baby ureteropelvic ureteropeloplasty, and we had no loss of function of the kidney, and we have no nephrectomy in our group. So in 2 cases we performed nephrostomy. And another question is, which antibiotics do you recommend to prophylaxis in UTD-free? Based on our experience, we use routinely amoxicillin clavulanic acid because also with discussion with our pediatric nephrologist in our territory, we have a high usefulness of the use of beta-lactamic antibiotics less than cephalosporin for the antibiotic resistance of our territory of northern Italy.
Great, thank you. Oh yeah, there's another question on the antibiotics one. I will pass it through right now.
No, we don't use routinely permethrin sulfamethoxazole, neither cefalexin. Like I said, the first choice is amoxicillin clavulanic acid, and then we use a first class cephalosporin like the cefaclor, but we are not used to Bactrim, and routinely we don't use it unless we have some resistant pathogens that, in which case we need to use that antibiotic. It is the same. Another question is the same attitude when the dilation is unilateral in UTD-free? Yes. And when do you consider a nephrectomy for patients with CAKUT? When we have a less than 10% function on the kidney involved, or when the patient has multiple refractory urinary tract infection or refractory arterial hypertension. And another question is, what about circumcision in UTD-free? We are working in this field because we are reading extensively the literature, and now we are considering the execution of a circumcision also in the infant period to reduce the risk of urinary tract infection. But by now, this is not our clinical aptitude, but we are implementing this field of treatment. Okay. Yes. After the nephrostomy tube, our experience, we put 2 nephrostomy tubes in our patients, and they show us that the kidney function was conserved, and then we performed ureteropyeloplasty. So in our group, our limited group, like you see, the numbers are not very much. We haven't done any nephrectomy. Another question, in the bilateral renal agenesis, there are space for give amniotic fluid to get lung maturation.
The lung maturation is made of amniotic fluid, but the problem in this case that if we start very, very early in the prenatal life, also repeated amnio infusion that doesn't work a lot to give a good lung maturation after the delivery. We are using this with when the amniotic fluid is leaked. We used to do this, but in this case, no.
How we can explain no difference between fetal cystoscopy and shunt in posterior uretral valves?
Yes, the difference, they have an increased risk of urethral fistula, the cystoscopy with laser, and also we are not using it for this reason. Most of all, the result on the neonate is the same after 1 year. So maybe there is an increase of neonatal survival time at delivery, but after 6 months or 1 year, it's the same.
Thank you. Those were the questions that came in until now. I'm just going to let attendees have a moment to type in some burning last questions. In the meantime, I would like to say that the webinar has been recorded, so we will put it on our GoToWebinar platform and our YouTube channel. So you will receive an email with the links for both of them tomorrow. If you're interested in our past webinars, you can also find them on our YouTube channel, so you can subscribe and you can find the list over there. And the attendees for today's webinar who have attended live, they will receive a survey immediately after the session has finished. So if you could fill that in, we can continuously improve further sessions. And if you fill the survey in within 2 weeks' time, you will get the EACME certificate from me. I see there is one last question, so I will pass this through.
Okay, in your review of patients, how did you choose which patients for observation group to include, or did you include it all? Well, I include in the observation group the transient urinary tract dilation, and in the outcome group, I included the patients that weren't done a surgical intervention or haven't a pathological diagnosis. And for the pathological diagnosis, we consider it the uretero-pelvic junction obstruction, the vesico-ureteral reflux, and the uretero-vesical junction obstruction.
Great, thank you so much. I think that brings us to the end of the webinar. So I would like to thank everyone that joined this evening, but also a big thank you to the presenters for the interesting presentations and answering the questions at the end. So yeah, thank you all very much and have a nice evening.
Thank you very much.
Thank you. Bye.
Bye.